Hello everyone. So in today's video we will get to know about gout disease, which is a metabolic inflammatory disease. The inflammation is caused by the WBC cells. So gout is caused by the deposition of monosodium urate crystals in the joints, which makes red, hot, tender and the swollen joints in your body. So when gout occurs, they known as gouty attacks. The another reason for gout is hyperuricemia, which means too much uric acid in the blood. They make formation of sharp needle-like crystals in the joints and the kidney tubules. If there will be repeated gouty attacks, they lead to arthritis. They often affect first metatarsal joint of big toe in the foot, which is known as podagra. You will feel like that your toe is on fire when you will wake up. There will be pain most severe in hours after attack, and it lasts days to the weeks. So we all know that the key component for the nucleic acids formation are purines and pyrimidines bases. So we should know where the uric acid is comes from. So when purines are broken down, they form uric acid, which are filtered out of blood and excreted in the urine. So the normal blood levels of uric acid is 2 to 6.8 milligram per deciliter, but when it exceeds 6.8 milligram per deciliter, then the condition known as hyperuricemia. Uric acid have limited solubility in the body fluids, so at pH 7.4, uric acid loses its proton and forms urate, which binds with sodium and then form monosodium urate crystals in the joints. The another reasons for its deposition are increased consumption of purines, example shellfish, red meat and organ meat, increased production of purines via higher fructose corn syrup beverages. There will be decreased clearance of uric acid due to the dehydration. Obesity and diabetes are the risk factors for gout. Chemotherapy and radiation and chronic kidney diseases also the major causes of monosodium urate crystals in the joints. Now we will study about the various drugs which are used in gout disease. So gout is of two types, acute gouty arthritis and chronic gout arthritis or hyperuricemia. The drugs used in the acute gouty arthritis are NSAIDs, colchicine, glucocorticoids. But for the chronic gout or hyperuricemia, the drugs used or classified in two types, which are uricosurics and uric acid synthesis inhibitor. Uricosurics consist of probenecid and sulfenpyrazone, and synthesis inhibitor are allopurinol and febuxostat. So first we will study acute gouty arthritis. So it is sudden onset of severe inflammation in a small joint, which is very commonest in the metatarsophalangeal joint of great toe. So NSAIDs, which are strong anti-inflammatory drugs, example piroxicam, naproxen, diclo, indomethacin or etocoxib, they may take 12 to 24 hours to act, but if you want the complete resolution, then it may take 5 to 10 days. But they are very tolerated drugs. Naproxen and piroxicam inhibits chemotactic migration of leukocytes into inflamed joint. They stop WBCs from moving into joint, so less inflammation and tissue damage will occur in the joints. So now we will study about colchicine drug. It is an alkaloid which is obtained from Colchicum autumnale. It is a pure form which is isolated in 1800 20. It is neither an analgesic nor anti-inflammatory, but it is specifically suppresses gouty inflammation. So when the acute gout attack occurs, there will be precipitation of urate crystals in the synovial fluid. So when these urate crystal forms, they are engulfed by the synovial cell and released mediators, and then inflammatory response started. After inflammatory response, chemotactic factors produced, and then granulocyte migrate into joint. They try to eat urate crystals and release glycoprotein and other chemicals, which worsens inflammation, and they lead to increased lactic acid production, which decreases local pH, and then more urate crystals will precipitated there. The another mechanism is releasing lysosomal enzymes, which causes joint destruction by the neutrophil burst. So colchicine inhibits release of chemotactic factors and glycoprotein, and it also inhibits granulocyte migration in the inflamed joint. So its toxicity is bloody, watery diarrhea, nausea, vomiting, abdominal cramps. In overdose, colchicine can do kidney damage, CNS depression, intestinal bleeding. It can also cause death due to the muscular paralysis and respiratory failure. But it is the fastest acting drug to control an acute gout attack. Colchicine is second line option to NSAID. The another drugs are corticosteroids. So the intra-articular injection of triacinolone acetonide 10 mg in small finger in toe joints and 30 mg in wrist. Now we will study about chronic gout hyperuricemia. So when the pain and stiffness persist in the joints between attacks, it is known as hyperuricemia. The drugs used for it are uricosurics, in which first we will study about probenecid. The mechanism of probenecid is that it is a highly lipid soluble organic acid which inhibit competitively active transport of organic acids by OATP at all sites. Probenecid inhibits penicillin excretion and increased sustained levels. It also inhibits reabsorption of uric acids, which increased excretion of uric acid and lowers its blood levels. It should be noted that aspirin blocks uricosuric action of probenecid, so they never be taken together. The adverse effect is dyspepsia. So in chronic gout, probenecid is second line drug to allopurinol. It should be used only when creatinine clearance is greater than 50 ml per minute or serum creatinine is less than 2 mg per deciliter. Patients with renal stone should not be given with probenecid. The another drug is sulfenpyrazone, which is a pyrazolone derivative related to phenylbutazone. The another drug is lazinurate, which is given alone or in combination with xanthine oxidase inhibitor. The another drugs for chronic gout are uric acid synthesis inhibitors, in which first we will study about allopurinol, which taken in actual form is short acting and is a hypoxanthine analog, competitively inhibits xanthine oxidase. But its major metabolite, which is alloxanthine or oxypurin, is a long acting and inhibits non-competitively xanthine oxidase. So the adverse effects are Steven-Johnson syndrome, which is rare but very serious risk. The uses first choice drug in chronic gout can be used in both overproducers and under excretors of uric acid. Secondary uricemia occurs due to the cancer chemotherapy, radiation, and thiazides or other drug and can be controlled by allopurinol. The another drug is febuxostat, which is non-purine xanthine oxidase inhibitor. The adverse effect is liver damage. The last drug in this class is pegloticase, which is recombinant uricase enzyme which oxidizes uric acid to highly soluble allantoin, easily excreted by kidney. Thank you for listening so patiently, and do subscribe my channel for more information about the other drugs. Thank you so much.